Next up in our international tour, we have Dr. Darius Marti from Freiburg, Switzerland, talking to us about a Swiss journey from the direct lateral approach to anterior approach. Darius.
Okay, good afternoon, everybody. Thank you very much for having me, Joe, for having invited me. My name is Darius Marti. I'm from Switzerland, the land of watches, cheese, and also a long history of orthopedic surgery. It's a great honor to me. As I said, I was invited by Joe. Joe joined our hip team in Freiburg about 2 years ago and has become a very good friend to me. I'm the co-leader of the hip and pelvis team and head of the orthogeriatrics team of the Cantonal University Hospital of Freiburg. My surgical activity is evenly split. Half of my caseload is dedicated to hip preservation, the other half to hip arthroplasty, including both primary and revision procedures. Freiburg is a bilingual city right between the French and German-speaking region of Switzerland, here in blue and red. The two yellow dots are Bern and Freiburg, which is located 30 kilometers southwest from the capital, Bern. I first learned the straight lateral transgluteal approach for total hip arthroplasty. Maurice Müller had modified the classical hard hinge approach, which was originally performed in the lateral position, into a supine version using his specially designed instruments. My initial training was under Emmanuel Gauthier, a disciple of Professor Reinhold Ganz, who himself had studied under Maurice Müller. So there's a strong influence of the Bernese school in Freiburg. We've always had the privilege of excellent mentors. The main advantage of this approach in supine position lies in its versatility. It offers excellent exposure of both the acetabulum and the femur. Cup positioning is safe and reproducible with the use of the aiming device, nicknamed the Sputnik, for obvious reasons. Here you can see an old video that I found from Maurice Müller using the aiming device in a supine position through the lateral approach. The supine position also provides a good control of femoral antitorsion. But this wasn't without limitations. Procedures took longer, and patients often experienced trochanteric pain or limp postoperatively. Full weight bearing had to be delayed in most of the cases. Our go-to femoral component was the MS-30, straight double-tapered stem from Zimmer, known for its reliability, for its good long-term outcomes. We always cemented the stem given our patient population and the need for immediate stability and predictable fixation. This also provided a good control of the femoral antitorsion. For the acetabular side, we used the press-fit cup and routinely added one screw for rotational stability. And we opted for a highly cross-linked polyethylene liner and a 32mm cobalt chromium head, balancing wear, resistance, stability, and also impingement. So here's the paradox. With the lateral approach, we had almost zero dislocations. Our outcomes were excellent. This was confirmed by the Swiss joint registry. By all standards, it worked. So why change? This was the critical question I had to ask myself. and the answer didn't come from complications or failures. It came from observing something better. So in 2010, I completed a fellowship at the Balgrist University Hospital in Zurich, where I was once again privileged to have a training under a student of Reinhold Ganz. Under the guidance of Professor Claudia Dora, I performed approximately 40 total hips using the anterior approach. The patient was in a supine position on a traction table. Here is the model of from Medacta, designed by Frédéric Laude. Besides a step-by-step surgical approach, I went to several cadaver labs. They were mostly sponsored by the industry. And so with great enthusiasm, I returned to Freiburg, and unfortunately, my chief, even though he was a fellow by Joel Matta, was not ready for change and referred to studies from that time showing more complications with the anterior approach. A Norwegian group compared their first 100 cases performed through the anterior approach to 100 cases performed through the lateral Hardinge approach. Although the anterior approach resulted in less blood loss and also shorter hospital stay, it was also associated with a significantly higher complication rate. So they were skeptical that the anterior approach could truly replace the established standard approaches. In 2015, I became an attending physician and left the cantonal hospital of Freiburg to a smaller peripheral clinic where the anterior approach has been routinely performed since the year 2000. And why is that? It's because my colleagues in the more western part of Switzerland, they were more influenced by the French surgical traditions and had adopted to the anterior approach much earlier than most of other Swiss surgeons. What really made me rethink my approach was not a journal article. It was what I saw in my own patients. I started noticing that even my fit lateral approach patients were recovering more slowly than older patients operated through the anterior approach by my colleagues. I'll never forget this one patient, that's actually the one, 4 hours post-op, walking out of the ward without crutches. That kind of early mobilization caught my attention. That was at that moment I realized if the anterior approach could offer this kind of recovery, it was time for a change. In 2014, a former colleague of mine, Daniel Müller, with Professor Dora, demonstrated that the adoption to the anterior approach was initially associated with a temporary increase in implant revision rates. However, this risk normalized after the first 20 cases, and the valuable lessons from a single surgeon's learning curve could be successfully transferred to junior colleagues. I had the privilege of being supervised during my first 20 cases by my senior colleague with extensive experience in the anterior approach. Thanks to his mentorship, I was able to regain very quickly confidence. The 2020 pandemic then led to a reorganization of our orthopedic department, and I was called back to my original institution. Meanwhile, we welcomed a new chief, Professor Moritz Tannast from Bern, who kindly invited me to join the hip team. Under his guidance, I became familiar then with the HANA table and Dr. Mada's surgical technique. Since then, I have continuously expanded the indications for the anterior approach, including the use its use in complex revision cases. So let me highlight some of the key clinical benefits I've experienced during the anterior approach. especially relevant for both primary and revision cases. My patients generally mobilized earlier, with less pain and faster functional recovery. This aligns with the published data and has been consistent in my own practice. For me, one of the strongest arguments for the anterior approach is the possibility to use direct fluoroscopic control. Intraoperatively, I can verify cup inclination and anteversion, as well as leg length and offset, leading to much greater precision. Thanks to that control, true leg length discrepancies have become a rare event in my hands. And when they do occur, they're minor and usually clinically irrelevant. Many think that the anterior approach is only for simple cases, but that's a misconception. With good exposure techniques, even complex revision cases like this one, where I had to use, well, initially I wanted to put in a Ganz reconstruction cage, and then I didn't use the 3-pound hammer, but still a heavyweight hammer, and hit too hard and it broke the anterior column. So I even had to go for a Burr-Schneider reinforcement cage, but I could easily do it from anterior, which I couldn't believe before. So it's totally doable. So before touching a patient, I recommend that you should get on hand-on experience with cadavers. It's the safest way to learn the anatomy and understand the spatial relationships of the anterior approach. Don't start it alone. Having an experienced mentor watch and guide your early cases makes the learning curve smoother and safer for your patients. In the beginning, select straightforward cases, no severe deformities, no short femoral necks. These cases give you space to master your technique before tackling more difficult anatomy. Posterior capsule release is key for femoral exposure. Don't underestimate this step. Releasing the ischiofemoral ligament is necessary to safely mobilize the femur and prevent complications during preparation and stem insertion. The traction table simplifies positioning, but it's not a substitute for understanding tissue tension and exposure. It helps, but you need to stay in control. If you have real-time imaging, then use it. Check cup orientation, leg length, and component alignment. It adds precision and confidence to each step. So having switched to the anterior approach, I'm not alone. According to the most recent series annual report, so the Swiss Joints Registry, the share of primary total hip arthroplasties have performed via anterior approach in Switzerland has risen steadily since 2015, reaching 56% by the end of the reporting period, which is 2023. So by now it should be also around 60%. Second to that is the anterior lateral approach, which is still very popular in Switzerland from the German influence from Röttinger's approach. So in Switzerland, it has become the most popular approach. This underscores not only the growing popularity of this approach among Swiss surgeons, but also the clinical benefits that have likely driven its widespread adoption. So I strongly believe that with the right guidance and support, transitioning to the anterior approach can be done safely. My early cases were supervised, which significantly reduced the risk and helped build confidence. Over time, I observed consistent benefits, reduced soft tissue trauma, better intraoperative control through fluoroscopy, and quicker functional recovery of my patients. This evolution is not only anecdotal. national joint registries and large cohort studies increasingly confirm that the anterior approach is gaining ground, not just because it's fashionable, but because it delivers on clinical outcomes. I was initially skeptical, as many are, but through experience, mentoring, and evidence, I moved from doubt to full adoption and now use the anterior approach even for complex revisions. So thank you for your attention, and if you're ever in Europe and tired of big cities, come to Freiburg, where the old town is beautiful, the fondue is hot, and the hips are well aligned.